thought about it.
Okay, we're doing case number 12, ankylosing spondylitis. Chris, Morgan, Michelle, and Trevor. Our patient's a 52-year-old male. He's married, has 3 children. He went to the doctor because he had persistent low back pain and stiffness during his activities of daily living for a few months. And the rheumatologist diagnosed him with AS and told him to take NSAIDs for his pain and stiffness, and also told him to stay as active as possible. 2 years passed, and his disease progressed significantly to where he went back to the doctor. The new doctor also prescribed him tenormin and prednisone in addition to the NSAIDs that he was originally taking, because the pain and stiffness had moved to his entire back, neck, and pelvis. He lives in a 2-story home and has 3 steps to enter, and it's got a whole flight to get to the 2nd floor. And there's a half bath on the 1st floor near the kitchen. Prior to all of his pain and stiffness going to his whole spine, he worked 45 to 60 hours a week, so he was really busy. Helped coach his son's hockey team and took his daughter to swimming lessons. So his family kept him really busy. He was active. He worked as a software, still does work as a software engineer, and we're going to use the ICF model to describe his condition and all of his activities and participation. His range of motion, his neck was 1/2 to 3/4 of normal. His trunk was 1/4 to 1/2 of normal, and like the typical AS shows, it was mostly his axial skeleton. His upper extremities and lower extremities were basically within normal limits. Same type of thing with his strength. His neck was fair minus to fair, trunk poor plus to fair. His upper extremities were okay, and same with his lower. He also had bilateral hip pain, 4 out of 10 on the left, 6 on the right, and this was mainly during his ADL, such as lifting, carrying, prolonged standing. He didn't have any pain at rest, only stiffness, so it was mostly when he was doing stuff. Sensation was intact. He had normal muscle tone, but his balance was somewhat impaired. He could only take moderate pushes from somebody else before losing his balance. His mobility, he needed assistance supine to sit for in bed, but he was okay on a firm mat. He was independent of rolling and half bridging, but not full bridging because the range of motion was impaired in his spine. Also independent sit to supine, to and from a bed and chair, and toileting with a raised seat. So he already had a raised seat to help him out with that. Needed minimal assistance supine to sit and getting in and out of the tub and shower, and also minimal to independent and sit to and from stand, depending on his transfer surface. For his gait, he was fully independent, but had increased pain when he walked longer distances, over at least a half a mile. He had decreased stance time on his right lower extremity and forward flexion of his hips and trunk. That was due to his hip pain. Poor trunk rotation. He walked pretty slow, and he had trouble stair climbing. He said it was strenuous and painful, but he could use the railing and do just fine. His functional mobility, he complete all his job duties as a software engineer, but the pain and stiffness bothered him, especially when he sat at his computer desk for a long time. He likes taking baths. It helps with his pain, but he sometimes needs help to transfer in and out. For his self-care, he was like I said earlier, he was independent in everything, but those tub transfers were tough for him. He could down and off his shoes, but he needed a shoehorn to put on his socks, and he needed help from his wife to down and off his pants. In the home, his pain and stiffness and lack of strength and endurance required him to hire some assistants to perform some of the duties, like mowing the lawn, shoveling the driveway, or other things like that. Some of his participation restrictions, he couldn't walk over a mile for exercise. He started getting pain at a half mile. He could no longer attend his son's hockey games. He used to be a coach. He can't even go to them now because the ice rink was too cold and he had to stand for too long there. He could no longer do some of his job duties because he can't sit for a long time period at his desk. And it was tough to keep up with his family life, to help out around the house and take his children to games and whatnot, so his wife had to pick up some of the slack. Some of his personal and environmental factors that we noted in the case. Some of the positive personal ones was he lived a very active lifestyle. He has since then had to decrease it a bit, but it's helped slow the progression of his disease. A negative personal aspect, though, is he didn't take an active role in learning about his disease. He just kind of went on with his day, and 2 years later, it's starting to really affect him. Some of the positive environmental factors, his family's really supportive. They're willing to help out with anything that he needs, and since he was the coach of his son's hockey team, they still do give him social support, and his work also supports him. They understand what he's going through. Negative, though, his house is a 2-story house, and he lives up on the 2nd floor, so it's tough to run up and down the stairs all day to and from his bedroom.
The main clinical problems that we're going to focus on are that the patient lacks strength in his neck, trunk, and lower extremities. He demonstrates decreased balance against moderate perturbations. He complains of bilateral hip pain with activities, more so on the right than the left. The patient also requires minimal assistance with transfers, limiting his independence. He is unable to exercise with his wife by walking 1 mile without pain and increased fatigue. He demonstrates poor trunk range of motion, decreased cadence, increasing the energy expenditure, and he's also unable to ascend or descend a flight of stairs without pain. He's unable to perform his home management duties due to lack of strength and endurance. His goals for therapy: by the end of therapy, we hope that the patient will report 1 out of 10 pain in his left hip and 1 out of 10 pain in his right hip with prolonged standing activities. Patient will perform supine to sit bed mobility for 7 out of 7 days independently. Patient will perform sit to stand transfers from lower surfaces independently. Patient will be able to bend down and pick up objects weighing 25 pounds safely with independence. Patient will ambulate 1 mile, demonstrating adequate trunk rotation and cadence without an increase of pain. Patient will perform self-care activities, including ability to bathe in tub and dress his lower body with supervision. Patient will be able to attend the full length of his son's hockey game without an increase of pain and stiffness, and will also address the need for assistive devices if that arises.
So for his plan of care, these are things that we will include. So bed mobility, transfer training, posture techniques to decrease pain and stiffness, gait training, strength training, self-care, and then education will also be included. These will help him reach his personal goals along with the therapy goals we have set for him. Interventions. So the first intervention we are going to do is bed mobility. This will include use of NDT techniques to promote sit to supine. Initially, preparation will be used and gradually assistance will be decreased until patient is able to complete bed mobility on their own. Transfers Next, transfer training. Transfers will include transfers to and from even surfaces, and then progression will include to uneven surfaces. In and out of tub transfers will be addressed, and possible use of a tub chair might need to be implemented for use to make the patient more independent and for safety measures. Thirdly, we'll work on posture. Patient will be educated on correct posture during sitting, standing, and sleeping at night. This will assist in addressing pain and stiffness and hopefully decrease those. Use of a correct posture will keep the patient in correct alignment as much as possible and decrease the wear and tear on other joints such as his hip. Also, to help keep the patient in these correct postures, like a nagging person could be an idea that would let him know that he has fallen out of these positions. For the fourth intervention, we're going to do gait training. So we'll have the patient on uneven surfaces, and we would like the patient to be able to decrease his pain while doing these. Therefore, the patient will have to gait train on level surfaces until he's able to complete this task with decrease in pain and stiffness. Once that is achieved, he will progress to uneven surfaces, and transfer to and from level to unlevel surfaces will be implemented into the intervention strategies. Also, stairs will be addressed, starting with a few steps and progressing to a full flight. During treatment, like I said, the patient should report decreased pain and stiffness. If the pain and stiffness is increased or stays the same, the intervention won't be progressed. For the fifth intervention, strength training. Strength training will, of the upper extremities, lower extremities, and trunk will be needed to be addressed along with a focus on areas of deficit and the body as a whole. This will assist the patient in endurance for posture muscles, also assist in strength needed to complete self-care, tasks, transfers, and possibly decreasing pain and stiffness. Self-care is next. This will be taught. Use of a reacher may be needed to make the patient independent in dressing of the lower extremities, but first modifications will be made such as bringing each leg up to apply pant legs. Lastly, education. The patient will be educated on ways to conserve energy, such as activity logs, washing dishes while sitting, taking breaks, and breaking up activities as needed, and possibly use of assistive device if that becomes what is needed. Also, new treatment options such as medication could be implemented, and he should be educated on signs and symptoms of his progression, such as notable stiffness with movement, increase in morning stiffness, or increase in pain. And then, as I had noted, use of assistive device. For his compensatory versus restorative treatments, compensatory, as mentioned, use of assist device such as a shower chair or possibly assist device for gait. Also, energy conservations with activity log or taking rest breaks, which you obviously don't normally do during tasks. Then restorative measures would be restoring his strength. We said that we could partially restore range of motion, but it would fully be restored due to the ankylosing spondylitis and then increase in ADL tolerance.
His comorbidities are resting blood pressure of 146 to 98 to 150 over 100, which is classified as stage 2 hypertension. He has a moderate decrease in balance and arthritis of his right hip. Changes in body systems with ages. In general, there's going to be a change in all his body systems affected. With the nervous system, there's going to be an increase in vasopressin, which is already going to increase his high blood pressure. Sensations are going to be decreased, such as vibration, light touch, 2-point discrimination, temperature, and pain. Balance issues also should increase, and he already has moderate decrease in that. Decreased learning, and uveitis, which is inflammation of the eye, which is one of the more common ones, since it's systemic disease, occurs in about 20 to 30% of individuals with eye pain, blurring of vision. And then neurogenic claudication and possible cauda equina syndrome can happen if osteophytes progress and thicken. In the cardiovascular system, some of the more common ones with aging are increase in collagen, fibrin, cross linkages, and decreased elastin, stiffening of the heart valves and venous insufficiency, decreased baroreceptor reflex, heart rate and blood pressure changes, and also an increase in deposition of adipose tissue and plaque in the arteries, which are going to decrease all his values. Hypertrophy of the ventricles and decreased O2 from decreased arterial size. This is all going to increase cardiac stress, along with increased peripheral vascular resistance increased and systolic blood pressure increase. More specific to AS would be stenosis, cardiomegaly, which is enlarging of the heart, pericarditis, which is inflammation of the sac of the heart, then aortic regurgitation or insufficiency, which is basically caused from the calcification of the aorta and thickening. And then amyloidosis, since it's a systemic disease, which is accumulation of protein. In the pulmonary system, you're going to see decreased chest wall excursion with involvement of the thoracic spine, along with costovertebral and sternal joints, which is going to cause difficulty inflating the lungs, upper lobe fibrosis, and decreased total lung capacity and vital capacity. In the genitourinary system, you could see irritable bowel syndrome, since it is systemic disease. In the integumentary system, you see decreased chest wall excursion if you see with the involvement of the thoracic spine and costovertebral and sternal joints. You could see psoriasis, but as far as with the skin, you're also going to see decreased elasticity of the skin, which could make it more susceptible to infections by breaking. In musculoskeletal system, you see 1/3 of people have asymmetrical involvement of the large peripheral joints, such as the shoulder, hip, and knee. Ultimately, this can lead to fibrosis, calcification, and ossification with fusion, early loss of lumbar lordosis, and increased thoracic kyphosis, along with painful limitation of cervical joint motion and diminished spine mobility in all planes of movement. Osteoporosis is common with compression fractures, AA subluxation, spinal stenosis, and morning stiffness that can last longer than 1 hour. As far as gait goes, it's common to see flexion contractures with a rigid gait, and then having individuals flex at the knees in order to try to maintain their upright position.
Okay, now we're gonna do a run through of our evidence review papers, and we're gonna start with the first one, self and manual mobilization, improving spinal mobility. So this study, it was a randomized study, and it was a randomized controlled study that evaluated the effects of self and manual mobilization combined to the entire spine in those who have ankylosing spondylitis. There was 32 middle-aged men used in the study, and they were randomly split into 2 groups. A treatment group that underwent their own self-mobilization at home using a home exercise program, and a manual one that a physical therapist did on the patients. Some of the sampling strengths of the study included participants whose their demographics were very similar, and all the members of the study had a pharmacological treatment. They used NSAIDs and disease-modifying anti-rheumatic drugs. However, some of the weaknesses were the treatment group had AS for about a year less than the control group, and they did a self-report on the patients, and it said that they were more mobile during just their daily life, which is sort of an unfair comparison, because if in 1 year having the disorder, it might 1 year less, like they might not be as severe as the control group. So comparing the two may not have been as fair of a comparison. As far as the design controls, some of the strengths, they used two blinded examiners who took all the pre and post measurements. So the PTs who were doing this, they didn't know if, or the measurers, they didn't know whether the person was in the control group or the treatment group. So there wasn't any unfair measurements, and all the people had their measurements taken at the same time of the day. People with AS, they might be much more stiff in the morning, or after sitting at work all day or something. So taking those at the same time of the day makes it a much better comparison. However, a weakness was that the control group was still able to complete whatever type of exercises they wanted to do on their own free time. So they may have gone home and done a bunch of mobility or spine activities to help themselves out. So we might have seen more of a decline in the control group if that weren't the case. Some of the limitations were that patients with bridging syndesmophytes in the T-spine were not included, and therefore the results can't be extrapolated to patients with bamboo spines. And also, they used a fairly small sample size, and so if there were other significant improvements that may have happened, they failed to detect them. For some future research topics that are similar to this, I suggested analyzing spinal mobilization in patients with long-standing AS instead of having it for, the patients in that study had it for only a few years. You could compare self versus the manual mobilization, because the current study compared doing a self and manual mobilization versus doing nothing. Maybe you could see which one is more beneficial compared to the other, self or manual. You could see maybe their NSAIDs or DMARDs were the real thing that was helping them. So maybe you could do a really similar study without taking them, see if it's not just the drugs that are helping them out, or just maybe more of a longitudinal study to see if there's any lasting effects of all these mobilizations, because the study was done in a fairly short period of time.
Alright, so for my evidence review, I did a study on radiological scoring methods for ankylosing spondylitis. My study was used, the purpose of it was to test the inner observer reliability, truth, discrimination, and feasibility of two scoring methods available for ankylosing spondylitis over a follow-up period of 3 years. The type of research was a comparison between the Bath Ankylosing Spondylitis Radiology Index and the Modified Stroke Ankylosing Spondylitis Spine Score. The external validity would have been the specific inclusion criteria and the sample size of 129 patients who fulfilled the modified New York criteria for AS diagnosis and attended the Department of Rheumatology at that place. Internal validity included 2 blinded trained observers to score the radiographs, inter and intra observer reliability, and good construct validity. The limitations of my study was the study only did a comparison between the 2 scoring methods, which there are numerous ones available. And the findings of my study concluded that the modified methods, the MSSS, quantified a higher portion of patients having radiographic progression compared to the Bath one. This meant that the modified stroke ankylosing spondylitis spine score was more responsive to change than the Bath index of the spine. Therefore, my topics for potential research would include further investigation into the accuracy of predicting progression and comparing other radiological methods. I thought this would be good. Also to compare how we as PTs measure ankylosing spondylitis, such as how much of progression was seen in radiographs to compare to how much difference in measurement has changed, such through measuring from like the occiput to the wall or side bending or any of those topics.
All right. The study that I looked up was adalimumab, I'm not sure, effectiveness for the treatment of ankylosing spondylitis is maintained for up to 2 years, long-term results from the ATLAS trial. This study is a open-label extended study for those who participated in the ATLAS trial. Its purpose was to assess the long-term effects of the medication used on patients with ankylosing spondylitis. And the medication was a fully human anti-tumor necrosis factor monoclonal antibody that is injected subcutaneously. So in this extended trial, out of the 296 patients that completed the 24-week trial, 261 patients participated in the extended study. The age ranges were from 18 to 71. 74% of those patients were male, and 96% of those patients were white. The patients who completed the ATLAS trial were eligible for the extended study. Patients were divided into 2 groups, either receiving the injections of 40 milligrams of the medication every week or every other week. The outcome independent variable scores were assessed and averaged at 12 weeks, 24 weeks, 1 year, and 2 years. Dependent variables were all of the following, and many were patient-reported scores. The findings of the extended trial noted that the positive changes that patients saw in the 24-week ATLAS trial were carried over, or they improved further. Some patients were even considered to be in remission from ankylosing spondylitis. The improvements were noted in the ASQOL, the AS-specific quality of life measurement, the SF-36, in the physical component, but not as specifically in the mental component, the BAS-DAI, and the MASES were the ones that showed the most improvement overall, and those measured total back pain, inflammation, and inflammation specifically of the tendinous attachment of bones on the spine. The rate of improvement was also noted to be the same between those who received weekly treatments as compared to those who received every other week. So that showed that less medication was having the same results, so patients didn't need to be injected as much. Limitations of the study. An internal validity of the ATLAS study and the extended study was that there are many different routes a patient could take once being involved in the trial. Once in the ATLAS trial, if a patient did not achieve improvements during weeks 12, 16, or 20, they were given 3 options where they could continue the study as they started, receive early escape therapy, where they just stopped the trial, or they received weekly injections of the medication. Those that chose to take the medications on a weekly basis were able to do so in the continuation study as well, meaning that this means that there was not a clear measure of the exposure of medication and how effective it is. And so by the time this 2-year study was done, not all patients had been exposed to the medication for 2 years. A majority of them had not even done 3/4 of the whole 2 years yet. Another external validity concern involved the small population size and the limited population type. If this, for future research, needs to be done with less variables and a more diverse patient demographic, and they also need to describe when patients receive the medication because that was unclear as well.
The study I looked at was the effects of a multimodal exercise program for people with AS. Type of research is a randomized controlled trial, and the purpose was to look at the effects of a 12-week multimodal exercise program in patients with AS. The sample consisted of a convenience sample taken at a university consisting of 30 individuals, 18 males and 12 females, with an average age of 24.9 years and a standard deviation of 6.28 years. Internal validity: all physicians were given by the same trained healthcare professionals. Well-explained protocols with supervision given to the experimental group, and a well-established New York protocol was used for classification of AS. The results were that the experimental group with the exercise program showed a significant improvements in range of motion, work capacity, and vital capacity compared to the control group, which only received information on exercise and did not receive supervisions. The main limitations of the study were that it was a small, convenient sample, and that they were referred from their physicians, and the overall young age of the population studied. So further research would be good to look at a larger sample size, looking at with an older population group and a longer study duration. So this one was only 12 weeks. The clinical implications were that a multimodal exercise program consisting of aerobics, stretching, and pulmonary exercises has value for individuals with AS for increasing range of motion, work capacity, and vital capacity in age group of around 25 years. Our clinical pearls were that some but not all of the improvements in range of motion were still present 4 months after termination of self and spinal mobilizations in patients with AS. In AS, the physiotherapeutic mobilizations 2 hours a week for 8 weeks, in addition to the patient's own exercises, increase spinal mobility. It is important that all patients adhere to their HEP in order to receive the best benefits. Patients who have not been successful with disease control with NSAIDs may show significant results with adalimumab or another anti-TNF monoclonal antibody treatment option. Multimodal exercise program, 50 minutes 3 times a week, stretching, pulmonary exercises, and aerobics has shown to improve range of motion, work capacity, and vital capacity. Then the MSAS is the best tool to use if the pelvis doesn't need to be included in to see the progression of ankylosing spondylitis, and it's important to educate patients on modifications and other interventions and keeping them as independent as possible.
And that's what I got to say about that.